Um, so let me just have you throw out some of the words that you think of.
Government.
Cool.
This is two, but bad electronic health record, EHR.
Wow. Okay.
Patient-centered.
So that was a positive in a positive way, right, Chris? Is that what we
Yeah,
heard?
yeah, they're not economic-centered or profit-centered.
Yeah.
Individuals with a variety of different experiences.
Say it again, Kaya.
Individuals with a variety of different experiences.
Are you talking about the staff or the patients? What were you thinking of?
I was thinking of the staff.
Okay. So the staff is experientially diverse. Okay.
Comprehensive is what I was thinking. They have like a wide scope of things they tackle.
Right. And out of curiosity, when you say that, someone, are you thinking that that's different from, let's say University of Vermont? Is it more comprehensive, less comprehensive?
I'm thinking, I don't know a lot about the VA, but from what I do know, I'm thinking more it's a wide breadth of things, but maybe not necessarily as specialized into each individual aspect of medicine, but they're kind of covering a large range of disease diagnoses.
Right. So perhaps broader, perhaps less deep.
Right.
Okay. Good. And thanks, Nemaya, for also saying that.
And I'll just add kind of what I was thinking when I put that on my list as well, because I actually had the opportunity to do a little rotation at the VA this past semester, and just seeing how the veterans were able to get referrals in house for like physical therapy, acupuncture, like things of that nature. That's kind of what I was thinking about the comprehensive nature of the care provided there.
Got it. So not necessarily all oh, medicalized. That there's some other the ancillary services are sort of embraced a little bit more comprehensively than perhaps you'll see otherwise at University of Central Florida Hospital, or whatever the name is of the hospital there.
And just being able to see them be able to have it kind of one stop shop and not having to do the runaround and go here and go somewhere else that patients often have to deal with.
Yep.
I was
Any
gonna
others?
say mental health.
Good. So that the mental health is integrated. So I'm not going to torture everybody by dragging out more. But feel free to pop more in the chat. One of the things that's so interesting to me is that, with the exception of the bad EHR, you guys all had very positive things to say, right? I mean, although who said government? I'm sort of
That
whoever.
was me.
Yeah. So is that a good thing? Was that a good thing or a bad thing, Hamza?
It's just the first thing I thought of. It
Okay.
depends on how you feel about government.
Right. Well, because I mean, right about now, if there's any single thing that separates people on the political spectrum, right, it's government. Is government good or bad? Does government help us or hurt us? And what's going on right now at the VA is fascinating on that spectrum because VA patients are amongst the most enthusiastic about their care of any patient group that I know. And it's very interesting. The vast majority of them say, I love my VA. I've heard terrible things about these other places, but at my VA, they really take good care of me. And some of these people are, interestingly, otherwise not enthusiastic about government. I was working at the White River Junction, Vermont, VA, during the 2010 elections, and a significant portion of my patients were saying that they would like to have either Bernie Sanders or Donald Trump as their president. Those were their favorites. One was a strong government provides services for the people, and the other one was a strong get government out of our lives. And so it was really kind of odd that this government-funded, government-run, not just single payer, but actually socialist. I'm sure that you guys know that the word socialism is often tossed around by some people, some of us as a good thing, and by others as horrific. But what makes the VA socialist is that the government owns the provision of care, controls the care that is provided, as well as handling the finances. So this is what's different, dramatically different between any of the single payer plans that have been proposed. And are you all familiar with the two Medicare for All bills that are in Congress, both the one in the Senate and the one in the House?
I'm not.
Okay, so these two bills are pretty similar. The one by that's in the House is probably a little bit more comprehensive, and the lead sponsor is Pramila Jayapal from Washington State, and it provides for a single pathway for financing healthcare, financed through progressive taxation, that will permit care providers of an expanded menu of services, not just the current Medicare one, but actually enhanced to include dental care and long-term care, as well as mental health. So there's mental health parity. But the care can be delivered by anybody, anywhere. The bill in the Senate, again called the Improved Medicare for All Act, with primary sponsor being Bernie Sanders, is similar. It does not yet have long-term care in it, and probably not in today's talk, but because the VA doesn't have very much in the way of long-term care either, except for very few vets who are eligible for long-term care. But the care at the VA is not just a single pathway of finance, but also the care itself is delivered at the VA, either at the large health centers, but also at community-based clinics throughout the country. And I might at some point, Chris, put you on the spot a little bit and ask you more about some of your experiences with the VA. But let me just ask you, did you ever go to a CBOC, or community-based outpatient clinic?
I did not, because I was not until recently considered to have a disability. Came up under the PAC Act. It's like a strange sort of thing, kind of a surprise to me. But I will say my wife worked as a psychology intern at a CBOC, and in fact worked at White River Junction.
Oh my!
Time as well. So I don't have that experience, but my wife has spoken a great deal about it.
Yeah, I mean, and it is very interesting. The VA does have small clinics in scattered around every state, and they all have close ties to the mothership, including very strong telehealth, so that the CBOCs are equipped with really cool technology, stethoscopes and otoscopes and ophthalmoscopes. Not so much the ophthalmoscopes, I take that back, but otoscopes and dermatoscopes, so that nursing staff at the CBOCs can place the tool on the vet's chest or skin area or in their ear, and a specialist or a primary care doc back at the mothership can make a diagnosis and interact with the patient. So again, what makes the government role in the VA so powerful is that everybody works for the VA, meaning the doctors, physical therapists, the people who develop the electronic health record, and thank you for talking about that, because I want to focus on that a little bit. The big thing that Suzanne is going to talk about if and when she gets here, and I was I'd forgotten that she might not be this reliable. The main thing that she's talking about now is the loss of that government socialism comprehensiveness. The big challenge to the VA right now is not just that it is underfunded. The VA gets its money from appropriations that Congress passes on a 4 to 5 year cycle, and it is chronically underfunded because it's a bit of a political football. The Congress people love standing around with vets saying, "I support our vets, I support our armed forces," but then they say, "And I'm going to cut the funding to show you that I'm serious about fiscal accountability." But the big thing that has happened over the last 15 years is a process of privatization of the VA. And it is not a loss of funding. The funding is still the single pathway. But in the name of choice, and choice is a strong American value that we want to be able, we're not Maoist China where we're told what clothes to wear. We want choice not only in our clothes and in our food, but also in our doctors. And so through a process that is largely funded through commercial insurance and strong healthcare systems, private healthcare systems, the VA is now, through the Choice Act and the Mission Act both, is being forced to pay for care delivered outside of the VA system. And initially it was just when there was either a specialty that was not available within the VA system, or that the wait time was too long. And I want to do a parenthesis here. If a vet found that wait time was too long within the VA system, the vet could apply for community care and have it paid for by the VA. However, oftentimes, and if anything, in a couple of well-done studies, the wait times were longer on the commercial side than they were on the VA. So in order to have this care, the vet would show that they were waiting too long, and then they would be approved to get it on the outside, and then the wait time would be longer in the private system. That again was the research that Suzanne did that other journalists did not follow back in 2010 and 2011. Then the next thing that happened was that a pseudo veterans, I'm blocking on the word, Chris, help me out here. The VFW and American Legion are veterans something groups. It's not a veterans resource group. There's a word for it. I think you might be muted. Or
No, I don't. I'm just.
okay.
I'm just,
Okay. Anyway, so a faux veterans research support group called Concerned Veterans of America put together some actually fallacious data saying that that veterans were not getting enough choice in their comprehensive care that was available through the VA. And so now veterans, under many circumstances, are allowed to simply say, I would rather get my care not at Tulane, but I'd rather go, I'm sorry, not at the VA, which is located, with apologies, I don't know, Chris, where it's located. If it's in New Orleans or up the river.
It's in New Orleans. The
okay.
major one is in New Orleans, right next to the University Hospital.
Yeah. And so vets can now say, I don't want to get my care at the VA. I would rather get my care outside. And the VA has, and again, Suzanne, I wish she were here because she can cite the studies, not done by her, but done within the VA, showing that there's more accountability for quality metrics within the VA than there is in any other healthcare system. But when patients say, well, I want to get my cardiac care not at the VA, but rather at Tulane, the VA, which ordinarily monitors the quality to make sure monitors the quality within the VA system, does not have any tools for making sure that the VA is getting its money's worth when people go outside. So there's no accountability. And the private healthcare systems, which lobbied to get this funding stream going, are getting paid at a higher level than Medicare or Medicaid by the VA. They're getting paid approximately 90 cents on the dollar. And again, I guess you guys are early in the internship, so I don't know whether they've compared the payment rates of different insurance companies, Medicare, Medicaid, Medicare for elderly and disabled, Medicaid for low income, commercial health insurance, which is primarily employer-based, TRICARE, which is for either active duty family or primarily for active duty family and retired military personnel. Each of them has a different reimbursement rate, and the VA is paying a higher rate. Waving goodbye to my wife, who's heading off to the pottery studio, which is air conditioned, as my home is not. And so right now, the VA is being caught by pincers. The total VA funding has been flatlined, and the VA is being turned into an insurance company to pay the bills from private healthcare deliverers. And then as part of that, unfortunately, this privatization is also part of a somewhat larger anti-VA movement by the Concerned Veterans of America, who are saying, well, since more of the veterans are going out of the VA system for their care, we can close some of those CBOCs. We can close some of the services, including mental health, at the VA. And I will say that having worked in private rural practice, having worked in North Carolina and in Harlem and at a semi-rural academic health center, Dartmouth, mental health is better integrated in the VA than in any other system out there. And not only is that my experience, but it's also documented in some pretty good studies. But what you guys need to do as up and coming leaders in healthcare policy, you have to master two streams of work. and you're going to be learning some of these techniques in the internship. You have to learn data and you have to learn narrative, right? Suzanne is the master of data. I'm not saying I'm the master of narrative, but I will tell you that when I have guys, actually men and women, and including some gender fluid people who I had in my office with anxiety or depression or PTSD that was deteriorating, I could literally step out, tell the nurse of my unit, I'll be gone for 20 minutes, hold down the fort. I would take that vet by the arm and we would walk downstairs to the mental health clinic. And I would say, I've got a vet here who needs some help today. Is that therapist available? And they'd look at their clock and say, yep, about 20 minutes. They are on call today. And I would then do a soft handoff of that vet who is in crisis to a psychologist or a therapist, and then go back upstairs and carry on with my clinic. And one final thing about the mental health is that there's excellent therapy for many conditions in the civilian world: depression, anxiety, schizophrenia, bipolar. And I'd be interested, Chris, whether or not I bored you, I keep on asking you, but it is my experience that combat-related PTSD and TBI, or traumatic brain injury, are things where the VA has superior care to any healthcare system in the nation. And Chris, you don't need to say anything. I'm just saying that if ever you want to interrupt me about any of these issues, please wave your hand. So I now want to give you another chore. I want you to write down, and by the way, I haven't forgotten about the bad EHR. We will come to that. I want you to write down 3 words when you think of VA patients. And Niemeyer, you've done an internship there. I don't know whether the rest of you, almost all of you will during your 3rd year, your clinical years. And those of you who are not in medical school, I don't know whether you ever will have experience with the VA, but almost all 3rd year medical students around the country have some VA experiences. And you get to have some thoughts about veterans. And forget the fact that we've got a veteran in our midst. Tell me what words you think of when you think about VA patients.
I can chime in quickly. This is also by no means a generalization to everyone, but just in my experience, I personally have some experience working with unhoused veterans or homeless veterans, which I know a large population of veterans have been experiencing homelessness. And especially with these budget cuts, I'm curious as to see how that's impacting them as patients at the VA.
So one subset is homeless veterans.
Sure.
And many of whom have concomitant mental health problems. Many of them have concomitant socioeconomic problems. And some of them have service-connected disabilities that tie into, that contribute to their homelessness. What are some other words or phrases that you think of?
I also put down, this is related to what you just said, that there's probably a higher percentage of disabled patients that are being seen by the VA.
And tell me a little bit more about the range of disabilities that comes to your mind, Macaulay.
I mean, I would think that there's probably, first of all, disability that has to do with, physical injury, as in combat. But there's also disability that has to do with, like you said, like TBI and even severe mental illness, things like PTSD, can be disabling. But if you have a population that's seen combat and has seen, situations where things can happen to their bodies that change them forever, you're probably more likely to just have a percentage of people whose bodies haven't changed forever.
You're 100% right. So higher rates of disability. It is very interesting. I don't know what the percentage of people who serve in the armed forces have been in combat, but it's less than half. And yet, the rate of trauma is still very high. These are high risk jobs that they do not only in combat but also in service, in mechanics, working. There's very physical and also very emotionally challenging. Tremendous loss of personal autonomy that can be very traumatic for people. The majority of women in the armed forces have been sexually traumatized. So yes, high rates of disability. Thank you, Macaulay. What else we got?
Say along the lines of homelessness, a high rate of like poverty.
Yes.
It's sometimes hard for veterans to return to the workforce and civilian life, so it can contribute to things like poverty and homelessness.
What's another cause of poverty besides difficulty returning to civilian life?
I mean, I think potentially disability can also factor into it, because if you have a disability, like you might be kind of unable to complete certain jobs.
Yep. So I apologize. I one of the things when I do faculty development for medical school faculty, I recommend they not ask leading questions or asking guess what I'm thinking questions. So I asked you a guess what I'm thinking question. There's a much higher rate of low income people who enlist in the Army. There's a much higher rate of poverty going in. This is an all volunteer Army. And people with better economic prospects or with strong economic prospects often do not volunteer for the Army. So it's more lower income people for whom the military is a step out of poverty. So these are people who, on average, come from lower income families. Then they go through trauma. They might have gained skills in the service that are applicable to civilian life, or they might have gained skills that have no bearing on civilian life. They may have gained no skills at all. They may simply have been taken out of the workforce for 4 years. And so, yes, there are much higher rates of poverty. And then another characteristic is these are people who are less likely to have health insurance. Where do most adults between the ages of 26 and 65 get their health insurance?
Employer.
Okay, so you see how all of these things sort of play off of each other. So yes, I think that most of us, when I think about my experiences before I worked at the VA, that these men and women usually had less money. They were less well employed, and there were some notable exceptions to that. University faculty, well employed, engineers who came to the VA because they really loved the VA. They loved all those characteristics that you described. They found the care to be superior, that the primary care doctors actually had more time with them than they did in the private world, that they could be handed off easily. I mean, God, when I got an X-ray, I would walk my vet down to the X-ray room and we'd look at the X-ray together with a radiologist. Oh, and I have to tell you a story. So I had been in academia and I was the associate dean of a medical school in New York City. And I came back to Dartmouth and I was trying to decide whether to practice at Dartmouth during the end of my last time in my career or go to the VA. And I went to the VA, and I was walking around, and I was asking people what they did. So I stopped this guy who was, I don't know, he was working on some equipment in the hallway, and I said, "Hey, what do you do?" He said, "Oh, I help take care of our veterans." He didn't say, "I'm a machinist who keeps the air conditioning going," which is what he was doing. I said, "What do you do?" I just stopped this guy, and he said, "I'm here to take care of our vets." And I said, "Okay, I want to work there. These are the people that I want to work with." And we have a wonderful population of vets who come there because they know that everybody is there to take care of them. What are some other words?
I was gonna say like unique health conditions, like a lot of environmental exposures that you really wouldn't see in other populations, like burn pits, Agent Orange, stuff like that.
Yes. These are what we call special programs. We have registries. Agent Orange has now been associated with a range of cancers, many of which don't reach the level of double-blind randomized controlled trials that our gold standard. But in association with various conditions is enough for veterans who have had some of these unique exposures to increasingly get service-connected disability payments and to be in those registries, to be followed closely. And there's some really good epidemiologists. We don't have the associations nailed down. So we are following those vets who have had those unique exposures to monitor their health care. And quite honestly, we need more funding to do that. But there are these special programs. I know I'm sounding like a VA booster, and there are problems. I got bogged down in more red tape than I could possibly disentangle. It was just friggin' ridiculous. If I wanted to spend money on something. The best time I ever had was when I was in private practice in rural northern New Hampshire with my wife partner. And we could set up our clinic for the patients the best way we could. Then the next was a hospital-owned clinic. And I could go to the hospital CEO and say, "I need a pulmonary function test." And he would say, "Are you sure?" And I said, "Yeah, I do." He said, "Okay, fine. It only costs $3,000, we'll do it." Academia, it was harder. The VA, oh my God. The forms I had to fill out, the hoops I had to jump through to make improvements was really difficult. And I'll give you an example. During COVID, I was doing telehealth. Somebody discovered that I had failed to recertify for CPR, for basic life support, which is one of the things you need to do to get credentialed. So they stopped me from doing telehealth because I had lost my certification to do CPR, which was mind-boggling because there I am on a Zoom screen with somebody, and they wouldn't let me take care of him because my certification had fallen. Like, nope, you can't do it. And it took them 3 months to get me recertified. That was typical VA government bureaucracy. So I'm a booster for all the great care, for the documentation of the care, for the comprehensiveness of the care, for dealing with unique health conditions, including particularly combat-related and exposure, for addressing poverty in unique ways, far better placement of care managers, social workers than I've had in any other clinic. So I'm a booster. And I also found it to be incredibly frustrating at times because of the, you know that the word snafu right? I think that came from the Army. Situation normal, all fucked up. You know, that's where it started, and the number of snafus that can happen when government regulations come in is huge. So I don't mean to sound like a Pollyanna. Nehemiah.
So that was actually one of the words I wrote down initially. It was like bureaucracy, because you know, with all the benefits I did see from being at the VA and my personal experience, I knew that there is that connotation some people have of, you know, being a government, you know, administered facility. You know, you have a lot of the red tape, as you mentioned. So I think that's kind of, in terms of the single payer movement, I think a lot of people at times, in terms of like physicians, will look at something like the VA as, you know, an example of what we have currently, you know, government sponsored, with, you know, its pros and cons, and they kind of look at that as an example of maybe why we don't want to move into single payer.
That is a great comment. Somebody else out there have a thought in that regard? Chris, were you going to answer that?
Not answer it, but I was gonna. It's along the same lines. It's like you wonder. Or I'll just, again, I'm incredibly biased, but I'm cynical of a lot of VA stuff. Not VA, but veteran stuff too. As I said, I think we whine a lot, and I will say though that it is always, you know, surprising to me that we have this great socialized type of medicine that we all do generally love our VA provider. But the reason why, and I just throw it out there, is if you've worked for the VA, you can understand why people who are veterans are oftentimes so anti-government. It's because it is nearly impossible to get anything done quickly, especially if you're not the general at the top. I mean, it's incredibly difficult. And then I think if you throw that into the military itself, where then they've got control over your whole life. I mean, you work. If it's 24 hours, you're being told to work. That's what you work. You know, there's no like, hey, I only have to work 12 hours today. You work whatever you're told, wherever you're told, under whatever conditions you're told. And the VA, and by the way, the military is awesome. I'm a huge fan. But that is what you get. And then you've got regulations from every single person above you, every congressperson who wants to create new rules, new training you have to do all the time. And so whereas I'm still cynical and I get embarrassed sometimes by what veterans say. And of course, you look at most of the January 6 people, I'm exaggerating, but a lot of them were veterans, right? I mean, and it's embarrassing on that sense, but their experience is that government slows you down and keeps you from doing what needs to be done. And the only way to get around it is to kind of skirt the rules. And in fact, the Army, you mentioned the Army, Air Force to a little bit lesser extent, but oftentimes encourages that sort of, we got to get there ultimately just in time with the solution. And sometimes that requires a less than perfect adherence to all of the rules, because the rules are so extensive.
Yep. So Nehemiah, let me take a crack at that. That is the main reason why the single payer movement doesn't talk about delivery of care. The VA, I'll tell you what the VA does terribly is act like an insurance company. The government actually is a great insurance company. Medicare is phenomenally effective and phenomenally efficient. The administrative costs of Medicare are, depending on which study you look at, in the 3 to 4% range. The administrative costs in commercial insurance is in the 20% range. And then additionally, for commercial insurance, they have to add in profit, because commercial insurance is required through our financial structure. If they are a public company, they are required to act in the best interests of the owners of the company. that is the shareholders. So a private company, insurance company, must act for the owners of Cigna rather than for the patients whose lives are covered. But so the people who confuse the delivery of care, which is inefficient, wonderful, but inefficient at the VA, with the payment of care, which is very efficiently done by government, are amongst the hardest people to talk with, because they say government, everything is government, right? So if the VA care is hard to get anything done, hard to make change, that's the way it's going to be with government-funded health insurance. And that's not the case. Government-funded health insurance is great at Medicare and almost as good with Medicaid. And which is why the single-parent movement only talks about financing. It doesn't talk about delivery of care. There are some, you guys are each, I think, probably going to be choosing a country to do an analysis of. And it'll be very interesting. I'd like to sit down and hear your reports. There's some countries like England, which is fully socialized. It's like the VA, only a national program. And there is now a small private movement for elective things, for plastic surgery, or people who are very wealthy who can go outside of the NHS to have their hip replacement done outside of NHS. But otherwise, everybody works for the NHS. With the exceptions of very wealthy people, if you have any friends who live in the UK, in England or Scotland or Northern Ireland, they love the NHS. Except they say, now I can't get in to see my doctor because there are not enough doctors to do it, and that's because it's been underfunded. So I look forward to hearing the report. If any of you, somebody please do the UK, and or some of the other countries, and with apologies, I'm not an expert on it. I don't know which other ones are fully socialized, where the doctors work for the government. I do want to say something about the EHR, and I know that we have. I did not know if this is an hour or an hour and a half period, but I'm aiming for an hour, and then we can open it up for more questions. The EHR at the VA is not one of the big modern ones that you'll find at almost all the hospitals that you work at. Epic is one that many of you are probably familiar with. Cerner is another one that you find at many large healthcare systems around the country. Hold on for a second, my computer's doing something really weird. There it goes, sorry. The electronic health record that the VA uses was developed in the 1970s. When it was developed, it was state of the art. It was absolutely wonderful. However, it has been barely improved since then. It literally does not have a word processing program built into it. So it handles all the encounters in a chronologically sequential fashion, regardless of whether they are primary care, subspecialty, or ancillary services. And so it is horrible trying to go back and track these things through. So all of us who work in the VA would like to have that system, which is called CPRS, to get an upgrade. What has happened, though, is that the DoD, Department of Defense, and the VA have both agreed to go with Cerner. And the DoD had more secure funding, and they have already begun to implement Cerner, but the VA has not yet done so. So we've been waiting for that implementation for 15 years. So you've touched on, and I don't know if that was you, Sam, that pointed out the EHR, one of the sore spots. But we're very fond of it in the same way that we're sort of sometimes fond of some other anachronistic things. At many VA hospitals, you might find 4-bed rooms. And I bet that at the academic health centers where you guys work, singles and doubles at the most. And some of our vets actually like the 4-bedrooms because there's this odd camaraderie of people who've been through the mill that Chris was talking about, where for 4 years, they own your ass. And they'll tell you what kind of underwear to wear. And having gone through those experiences together, and even more dramatically, if you've gone through combat together, there's something of a camaraderie that I've seen in the waiting rooms at the VA that I don't see anywhere else, and that I've also come into these 4-bed rooms and these guys are just talking to each other, and comparing units, and I took care of a lot of Vietnam vets. That was my era, and it was pretty remarkable. Anyway, so there are these anachronistic things that seem like a bit of a throwback, and at times we're almost fond of it the way that we're fond of our outspoken crazy uncle who shows up at Thanksgiving and says stupid things, but we love him anyway. So there's some of that about the VA. So I had been aiming that Susanna and I would do this for an hour. I'm sorry that you didn't get a chance to meet Suzanne. She is a knockout in her mastery of the data. But I know that we probably have a little bit more time. I think we probably were scheduled for an hour and a half. Is that correct? Somebody know? Okay, so let me open it up for questions and comments. And because Suzanne is not here, I'm happy to talk about anything you want. I told you my own personal story, so I'm happy to chat. But then do you have another thing coming on it at 2:30, or is this the last thing of the day?
This is supposed
Our
to
next
go
thing is at
until
3. Oh, sorry.
2:30. Yeah, and then the next thing is at 3.
Okay, so if we stop it in 15 or 20 minutes, it won't hurt anybody's feeling to be able to go off and get some other stuff done. Okay, so does somebody have some questions or comments?
I just wanted to say I had also written down community as one of the words I was thinking of just from what I've seen. My dad's was with law enforcement, so not the military, but a lot of ex-military people that he worked with, and the community that I've seen through his own community through law enforcement of veterans and whatnot has been pretty strong.
Yep. That is quite true. There's amazing camaraderie that is, I won't say it's unmatched. People who do athletics at a serious level can develop but develop strong relations. People who have to work intensely under adverse circumstances and who are mission driven to get the job done, no matter how hard it is, and then to depend on each other to get the job done. It is really inspiring. At times fierce, and at times exclusionary, which doesn't always work to the veterans' benefits. But thank you for mentioning that, Gabriella. It is a good feature of it. Were there any other words or thoughts that people had?
I had a question. Also, thank you for this talk. It's been awesome. I've definitely learned a lot. But I was interested, I know one of the big talking points of like single payer is getting rid of prior authorization. And so I was kind of curious, the VA, the government is funding everything. So is there anyone that you have to get certain tests approved by, or you kind of have a lot of autonomy as a physician?
You have a lot of autonomy. And there are, I'll use two examples. One of them is medications, and then the other is radiology. And I see your hand, Shelby, so we'll get to you next. Way that the VA handles medications is, number one, we are allowed by law to negotiate prices, which by law until recently Medicare and private insurances have not been allowed to do. And so what can happen to VA is we'll say, we want to have 3 NSAIDs, non-steroidal anti-inflammatory drugs. They'll go to the manufacturers and bargain to get the best 3, and there are committees to determine the efficacy, safety profile, and price. And those are the 3 that we offer. When you order a medicine through the VA pharmacy, if you order another one beyond those 3, the pharmacist will say denied, and you have to write back and say, oh, here's the reason why, or actually there's an online form. So if you know that something other than those 3, you just write down that they've had the adverse reaction to the first 2, and it gets approved. If there's a new drug that hasn't been available through the VA system, then there's a mechanism to apply for it and make a case for why your patient should have that. So we have an excellent formulary, and then we do have sort of for these other drugs a prior auth process. However, it's done by VA pharmacists who are the same people who I ran around and I met them in the hallway, and they said, we're here to take care of our vets. The problem with prior authorization, and this is primarily, by the way, right now with Medicare Advantage, which is a whole other talk about Medicare funding going off to having a commercial insurance controlling. They limit care, and their job is to, and we've got good documentation of insiders who've told us that their game plan is to make life so difficult that people say, screw it, we'll just stop trying to get the prior auth. They put roadblocks in. Radiology is a wonderful other example. We have too many MRI machines in this country as compared to other industrialized nations. The VA is pretty much right-sized for the number of MRIs that we need. So if you're an orthopedist who used to work in the commercial system, in the civilian world, and was accustomed saying, I'm going to get an MRI on every knee I see. And there are many orthopedists who do that. I want you to get your MRI before you come in. They get to the VA, and the VA said, no, we only have 2 machines to serve this entire region. You've got to have a better reason to get an MRI of the knee than just you want it. You have to do an exam first. You have to give them 3 to 4 weeks. If your exam is not consistent with a lesion that requires an MRI to discern it, then if your exam is completely consistent with an ACL tear, you don't need an MRI to prove it. The exam is adequate because you have to do a good physical exam. And otherwise, if it's for a medial meniscus tear, you actually have to wait, give them good PT for 4 to 6 weeks, because you're not going to do anything different than give them, if your exam is consistent with the medial meniscus tear, then wait to see give them good PT, and they get it in 4 to 6 weeks. You're not going to repair that medial meniscus. You're going to do it, you're going to use the same clinical pathway, whether you had the MRI or not. And so if you put in for the MRI, the answer will come back, no. Give them good PT for 4 to 6 weeks. And I've had occasion where I've walked down and I've spoken with the radiologist there, and I said, look, this guy is freaking out because of his PTSD. He's unstable. Let's give this guy an MRI, because otherwise he's going to be suicidal over these next 4 weeks. And I make that case to the radiologist who's literally just down the hallway, and I get it. Serby, what are your thoughts?
Yeah, I was actually going to ask you, you have like a very unique experience working in the VA Medical Center. What kind of advice do you give to us as future physicians? And I know two of us are health advocates, but like what advice do you give to better care for veteran patients?
The first thing is that every patient should be asked at some point early in their care is, have you ever served in the military, or has anybody in your family ever served in the military? And don't say, are you a veteran? Because there are many men and women who have served who feel odd because either they weren't posted overseas or they were not in combat. And they sort of feel like they don't want to take resources away from people who, quote, need it more. And so ask everybody, have you served in the military, or has somebody in your family served? And it is just amazing the stories you'll hear. And by the way, for spouses of military veterans, there's some unique challenges that they face that all providers should learn about. And listen, the process of becoming a doctor is long, right? Medical school, residency, you don't have to learn everything right away. So and with apologies, I can't show it to you right now because I've got a lot of boxes around here. I just redid this room and everything is a damn mess. But I have these cards that I give out to all doctors, young doctors in training, that list all those special exposures that veterans are prone to, that talk about some of the unique psychological and family stressors that veterans face. And then some of the unique, not the unique illnesses, but much higher rates, as Macaulay was pointing out, of traumatic disability as well as psychological disability. You don't have to master the care of them, but you should, just as we all now ask, are you safe at home? And we ask that of patients. We learn how to ask about how to take a good sexual history. Do you have sex? Do you have sex with men, with women? What is your sexual identity? What is your gender identity? Are you gay or straight? Have you served in the military? Learning how to ask these questions, which are difficult. And if you're going to ask the question, you have to be able to handle the answer. And a lot of medical training is helping you develop the self-confidence so that, if I ask Chris some story about his personal history or his health history, I want to be able to handle whatever crap he throws at me. So I need to be psychologically stable enough myself that I could, whatever he tells me happened to him, that I won't get knocked off my pins. Or, I can say, okay, that is a lot of stuff. I need some help. So that is my main thing to say, is to ask everybody at some point. Now, if it's a child being brought in for a strep throat, you don't have to ask the child's parents at that time. Is anybody? But if you're a pediatrician, you're taking care of children, you should know whether or not their parents are veterans of military service. To know what resources are available, the unique resources that we spoke about at the VA, and to know what some of the challenges are that are unique in that situation. The second thing that I recommend is that you know more about what is available. And again, this may not be until you're a resident, because it's some of this stuff is too much in the weeds for you as a medical student to understand the difference between, getting a CT angiogram in situation A versus a PET scan in another. Don't worry about that. But when you are a resident, particularly when you're a senior resident, guiding and teaching the younger ones, learn about the VA system around you. Where are the CBOCs? If you've got, and it's amazing to me, there's residents down here at Dartmouth, some of their patients come from 2.5 hours, 3 hours drive away up near the Canadian border. And the residents down there, have no idea what's going on out in the community. Zero idea. Their world is just this cloistered 4 walls of the academic health center. Find out what's available in community care, and not in the civilian world, but also where the CBOCs are. And can somebody who has served, or somebody in the family has served, can they get care there? I don't know whether I addressed things that you were thinking of.
You did. No, it really opened my mind, a lot of the advices that you gave. So thank you.
Okay. Yeah. Are there some other questions, comments, or observations? I'll give last word, not to Chris, but to the 2 health advocates, right, who are not going to be doctors, right? That's Kaya is one, and who's the other?
That would be me.
That would be you. So Kaya and Gabriella, you're not on the doctor path. What are your final reflections and takeaways here?
I can go first. I don't know. I think Kaya is pre-med and just not in med school yet, right? I don't want to speak for you, Kaya. Is that
okay?
Yeah. I'm looking to do advocacy work through potentially pursuing law school eventually. So I think a lot of the advice that you gave is still applicable. It might not be working directly with patients, but still being able to build connections in communities, and ensure that access that people need is being represented on other levels as well beyond direct patient care. I don't know what that's gonna look like for me exactly just yet, but we'll see. And I appreciate you taking the time to enlighten us on a lot of those.
It was a pleasure. Just a sidebar, if you have not yet met Lucy Hodder in the UNH Franklin Pierce Law School, she had been the director of the Health Policy and Law Institute, and she's now sort of on a sabbatical. And she is absolutely amazing to see how law can help improve care.
Yeah, I hadn't remembered her name when you immediately said it, but I actually I was part of the pre-law society at UNH, and I was able to meet her via Zoom during COVID my freshman year and hear from her. And she's had a pretty spectacular career. So yeah.
She has taught me so much. And I have to say that one of my first ideas about healthcare is I wanted to work in a community center that had doctors, dentists. Oh, that dental care in the VA, that's a whole other talk. Doctors, dentists, lawyers, architects, social workers, teachers, food advocates. It wouldn't be wonderful if we could work in a system where there's that kind of interprofessional matching to bring people what they need in regardless of their community. And Kaya, I'll give you the last word as a pre-med.
Thanks for that. I don't really know where I'm going to end up quite yet. I don't know if I'm going to end up going pre-med or I'm going to end up going somewhere else. I'm hoping to do a master's program and then kind of get a better idea of myself and then what I want to do with medicine and then go from there. But I love doing stuff like this. I love learning about the different avenues with medicine, the different ways it impacts certain groups and individuals and communities. So I'm always happy to hear and to learn. And thank you so much for an awesome lecture.
Well, you're quite welcome. Thanks, Chris, for your assists along the way. Thank you all. I wish you all the very best. The leaders of the internship know how to reach me. And actually, I can put into the chat my um, my email, and I'd be happy to interact with you either as individuals or as a group later on. And I apologize, I was not looking at, didn't keep my eyes on the chat, but good to see what was written there. Very physical work as well, you betcha. So again, thank you. Have a wonderful internship. Learn lots, have fun, work hard, kick ass.